Good afternoon, everybody. My name's Stephanie Robert. I'm director and professor of the School of Social Work, and it's my pleasure to welcome you all here today. I know it's kind of a strange room, and this always happens. People spread out, right, in rooms like this, but hopefully we'll have a cozy conversation nevertheless. Before I get going, I would like to give a special welcome to members of the School of Social Work's Advisory Board who are here today. So we have Gary Cohen, there's Gary, Roberta Gassman, Trudy Marshall, and Marcy Bradley. So we're having an advisory board meeting tomorrow with them in person and some of our folks by phone. So thank you to our advisory board for making events like this possible. Although today we have a different sponsor. Oak Park Place is sponsoring this talk today, and we're very grateful to them. They help sponsor a number of events on aging and health. And as we will talk about today, with our aging society, it's more important than ever that we have a focus on aging and health. And I'm going to put in a special plug. We, for the first time in our part-time MSW program, have special focus areas on both health and aging. So if you or anybody you know wants to get your MSW in our part-time program on Saturdays, and are interested in either health or aging, that is something that you're able to do. So if you're if you're interested in talking more about that, find me at the end and we can chat. So it's my pleasure to introduce to you today our speaker, Dr. Joan Levy Zlotnik. She, right now, is senior consultant to the National Association of Social Work, which is our professional social work organization. Most recently, she was the director of the Social Work Policy Institute, which is a think tank with the NASW Foundation that focuses on bringing social work's knowledge to, and voice to policy change. So let me back up a little bit and talk a little bit about her history. She got a BA from the University of Rochester. And also, in what must have been the pinnacle of her experience as a young adult, she got her MSSW from the University of Wisconsin-Madison. So we expect that it was this experience that launched the rest of her illustrious career and that brings her to us today. After that, she also earned her Ph.D. in social work from the University of Maryland. Now, I am not going to go through her whole CV because I know of very few people in social work who have had as many leadership roles as she has had. And what's remarkable, I think, about her leadership roles is that she's been a leader in social work in education and in policy and in research. And that's very rare to be a leader in that combination of areas. Usually you're a leader in one of those areas. I'm going to give you just a couple examples of the types of roles that she's had. She was the executive director with the Institute for the Advancement of Social Work Research, working to build social work research resources and to translate research into practice, policy, and education. And I know firsthand that she worked tirelessly to try to get the National Institutes of Health to fund well social work research. Another example, and where I first met Joan, was when she was part of the Council on Social Work Education, CSWE, their Strengthening Aging and Gerontology Education for Social Work initiative, which was called SAGE Social Work. This initiative worked to develop gerontological social work competencies and disseminate models of best practice in teaching gerontological social work. You wouldn't be surprised to know that she's received numerous awards over her career. So I am not going to go on and on. Instead, I'm going to leave the time for her so she can tell us everything she's learned in her career. So it's my privilege to introduce Dr. Joan Levy Zlotnik, who is going to talk to us about the challenges and opportunities of a growing population of older adults. And she's promised to highlight how, where, why how, where, and why a well-prepared social work profession can play important roles in improving health outcomes. Welcome, Joan.
Thank you, Stephanie, and I'm really so pleased to be here. I haven't been back in Madison since I left at the end of my social work education in 1974, so it's been 42 years since I've been in Madison. It was kind of remarkable because I was counting up actually how many schools of social work I have been at, and always kept thinking, well, I should go back to Madison. So I was really excited when Steph invited me to come, and I think it was about last February or so that she invited me for like October. And I guess one of the things about aging is it's like, October? What will I be doing in October? I don't know. So I came to Madison as a young 22-year-old. I was a product of New York City, and so I had graduated from college at 20 and had done some work. And my mother thought that I needed more direction in my life and I should go to graduate school, and I wasn't quite sure what I wanted to do. So I chose to apply to 2 social work schools and a school of voc rehab. And I applied to social work schools based on the fact that I applied to 2 schools because they didn't require the GREs. I mean, I could just show you how motivated I was to do this. And in reality, I think my experience at the University of Wisconsin-Madison School of Social Work from 72 to 74, kind of at the end of a period of great unrest in Madison, really changed my life and gave me some focus. So, what do I want to do here tonight? I want to talk a little about how did I get here and to the roles that have been so pleasing in what I've been able to do in the profession, and have done those work mostly in child welfare and in aging. So not too many people do one or the other, and it's sort of across policy, research, and education. And then I want to kind of talk more specifically about the challenges that exist as we sort of collide with the changing demographics. And since I am now part of those demographics, once my friends and I all got our Medicare cards and are part of the old, and when you hear the news and they talk about this elderly person who's 68, and it's like, elderly, everyone I know is 68. What do you mean elderly? Or think about, well, I had a great aunt who was 98, and she was like the only person who lived into her 90s, and then I think all the relatives that we've had to live to 96 or 99 or 100, like the demographics have really, really changed. So we want to sort of talk a little about those demographics and how they kind of collide with the changing healthcare strategies, and a little about what the sort of Post-Affordable Care Act world means for social work, talk about some of the innovations and focus on outcomes, and think about where social work is now and what kind of lies ahead for the profession. So I'm going to try to cover all of that in, 20 minutes or less. So first of all, I think my experiences at the University of Wisconsin-Madison just contributed greatly to who I am as a social worker and what I've tried to impart to many other social workers throughout my career. I was here sort of in the height of the Pincus-Minahan systems approach to social work, and it left me grounded for the rest of my career to not divide everything up into sort of casework, group work, community organization, and with all of the focus right now in the social work profession around macro practice, I still go back to the fact that there's all different kinds of interventions and they're all needed and necessary. Also, I did my field placement my first year at what was then the Diagnostic and Treatment Unit, which grew into the Weissman Center. Mona Wasow was my field instructor, And once again, that became really important. So I've had this paper that I've been carrying around for 42 years that I wrote for, I must have been like sort of Ann Minahan taught this like integrative seminar at the end of school. So I have this paper called Me, a Social Worker. And every once in a while I go back and read it, and I talk about, you know, when I entered the school, my whole head changed. In a lot of ways, my sociology background and concern for how society labels people and makes them deviant began to overshadow my desire to play head shrinker. The DTU was far from my first choice. I knew nothing about mental retardation and didn't know I had any interest in it. Yet for the first time in my life, my experience at the DTU gave me direction. I became interested in normalization and keeping people out of institutions that don't need to be there. I lost my desire to do one-to-one therapy and became interested in program development and policy change. And I've pretty much pursued that career for the next 42 years. So it was very prescient, even though I didn't know it at the time. And as I was saying to a group of students earlier today, it was particularly hard because I was from the East Coast. So I left Madison, where the talk was as an MSW, you would be a supervisor and a manager and a program developer, and went back east and started working. And my first job was in Massachusetts. I worked about 10 miles from Smith College School for Social Work, which is kind of the bastion of sort of Freudian thinking. And you know, East Coast, lots of schools of social work, very, very psychodynamic. And so it was really sort of a culture shock to kind of go back there in terms of my friends who had gone to social work school there and the kinds of jobs. But I really was able, from the beginning, to pursue opportunities that really had to do with developing programs and kind of changing the way services are, and to always be able to be sort of part of coalitions and work groups and strategy think tank kinds of things that sort of led me eventually to the National Association of Social Workers. I came to DC in 1987 and thought, oh, it would be great to work at the national level. But it was really important, I think, as I reflect back on it, and I tell this to students all the time, that being grounded in service delivery and practice, I think, helped make the work I've done at the national level much more strategic and valuable than if I had just really come and didn't really have that kind of grounding in program and service delivery and working with families and just kind of wanted to change things, but I didn't really know kind of what to change and how to change them. So I think that was really important. And interestingly, over the years, I got to know a lot of people who have been great colleagues in my social work career who all had actually gone to the University of Wisconsin. Carol Austin was my field instructor in my second year, first semester field placements, and we stayed in touch for many, many years. And when I went to NASW, she was the chair of a big committee at the Gerontological Society and kind of, you know, made some of those bridges. Ann Nichols Casebolt, who is the board president for the Institute for the Advancement of Social Work Research for 6 years, Jean Quam, who had been president of the Deans Association, Alice Lieberman, Christy, that's Christy and me at a briefing on Capitol Hill about poverty and child maltreatment. And on the right is Suzanne Edelman, who I went to college with. She came to Madison after me. She is a hospice social worker and does crisis intervention work in the Jewish community in DC. And we had one of our young, friends of our daughters who was applying to social work school and applied to Madison. And I remember when she put together her thing, she was like, well, it must be a good school because here I was doing all this policy work and Suzanne was like on the ground and doing all this clinical work. And obviously you could learn all those things in Madison. So, that's me in 1972 and about 1987, and more recently, including with my daughter, who has a joint social work public health degree from the University of North Carolina, And she was working on children's health policy, and we've been able to do some things together. So that's with Congressman Ed Towns and Janet Schneiderman from USC, and Brian Samuels, who was head of the Administration for Children, Youth, and Families, at another congressional briefing that we were able to do. So that's sort of some of how I've changed over the years. So my perspective, I worked at NASW from 1987 to 1994. I worked at CSWE from 1995 to 2000. And in 2000, I was asked to serve as an interim and then got the full-time job as the head of the Institute for the Advancement of Social Work Research. And that was a pretty incredible position because the IASWR had already been around for 7 years and it had 3 directors in those first 7 years. Then I was there for 9 years. And I worked, every day with the National Institutes of Health and with other federal agencies and with members of Congress to really help build social work research and to also work with the social work community to really build capacity and change some of what was happening and give much more visibility to the great contributions that social workers were making in research, because they just weren't a natural audience, because people think of social workers only as practitioners. So that was really important. And national organizations play really important roles. I know different schools have different sort of approaches to how they educate students into the profession and into the roles that organizations play. But professional associations play important roles in terms of leading efforts on behalf of the profession. And one of the challenges for social work is because social work is so broad, what I always want to do is get a group of people together in the room who care about aging, who care about child welfare, who care about substance abuse, who care about macro practice, who care about research, who care about child welfare, and kind of get them all in a room together and figure out how hard it is in an association to sort of, with limited resources, like how do you sort of develop an agenda that kind of can incorporate all of these different kinds of things, because it's a challenge. I was once meeting with people at the National Institutes of Justice and was talking about all the different areas that social workers work in schools and this and that. And this guy from NIJ said, gosh, we have enough trouble just dealing with crime and delinquency, much less, all these other things. So it's important to appreciate that. Professional associations have important roles in terms of advocacy, and that includes with both the legislative and the executive branch. And a lot of my work has been particularly with the executive branch, developing relationships with people at federal agencies, at the National Institute on Aging, at the Administration for Community Living. We were able actually, in this project, Social Work Heals, that we have, we had all the students come who were getting BSW and MSW scholarships from 10 schools, and we wanted them to meet some policymakers who were social workers, and we had Aaron Bishop, another graduate of the school, come and talk to the students, and they were kind of blown away by, his career and what they had to say. We have important roles in convening, and certainly as my role at the Social Work Policy Institute as a think tank, we did a lot of convenings and bringing people together to develop agendas and to sort of move forward. And then for many of those, we did sort of Hill briefings on Capitol Hill as follow-up. Publications, newsletters, and journals are important. Engaging the press and public, and really sort of important roles as social workers and in associations to be able to speak for the profession. And I've certainly appreciated the opportunities I've had to do that. Setting and guiding the agenda, and one of the things we'll certainly be doing, or NASW I'm sure will be doing, as the new administration post-election takes place, is developing transition documents about what are the critical issues that social work has a say on. And most importantly, and I think perhaps the things that I learned here at the University of Wisconsin were really about connecting and brokering and the importance of relationship development. And I have to say that when I came here, and I was, a year out of college, year and a half out of college and young, I was someone who, like an undergraduate, never really talked up. And somewhere in some class in when I was in Madison, I started talking and speaking up, and I haven't actually shut up yet. So this, really been pivotal, I think, my experience in Madison. And it's a language that people learned. Years ago, I worked with someone. We had both been here at the same time. We really didn't know each other, both in the School of Social Work. But we could speak the same language because we'd had that same experience. So I want to switch gears a little. I was kind of asked to talk about health and aging. And so what I wanted to do first is kind of provide some demographic information. These are things that many of you know, but just really, I think it helps provide a context about the aging of our society and how it's really different. And I guess I really feel it in terms of my own aging when I can come here and say, oh my God, I left here 42 years ago, but I'm only like 38. So like, it's really hard to fathom. So the population over age 65 has increased 28% since 2004. 1 in 7 people in the United States are older Americans. The 85-plus population is projected to triple from 6.2 million in 2014 to 14.6 million in 2040. And that's really important, and I think we're all seeing that in our own families. It's very different, and when you think even of like cutting back at working, as I was doing, last year, it's like, but I could still be cutting back at working and work for another 30 years. I mean, it's a very different effort. The difference also in terms of racial and ethnic minority populations. I live in Montgomery County, Maryland, and just data came out about whites in Montgomery County, which used to be about 80% white, are no longer in the majority at all. Populations everywhere, California, everywhere, are changing. The racial and ethnic minority population has increased from 6.5 million in 2004, which is 18% of older adults, to 10 million in 2014, which is 22%. And by 2030, it's expected to be 28% of older adults. And that there were 72,197 persons aged 100 or more in 2014. And you see, for those of you who watch the Today Show, and they're still doing, even though Will Scott's not doing it anymore, the people who turned 100, but now it's like people who are 107. And some of the issues are, what's people are living longer, but what's the quality of their lives, and what are their needs, and are they being met? So I, took a bunch of statistics from the federal statistics that I thought would be very useful also. And so this is just looking at population over 65 by ethnicity, and sort of here you have 2014, and then the striped lines are projected for 2060. And you see the shrinking of the white population, and particularly of significance are the changing of the Hispanic and I think Asian populations, really different in our society. Also of interest is populations over 65 and their chronic conditions, and I think this is a big issue that impacts healthcare delivery in terms of heart disease, hypertension, stroke, asthma, and these are the differences with men and women. So you certainly see like arthritis, more so with women, heart disease, more so with men, cancer a little more with men. And these are, people are living with multiple chronic conditions. Just in terms of health status, this is just some differences by race, and you see the brown bars are sort of the total, but if you look at the white or the dark green bars on the left, and you just see the differences, and you see the differences as populations get older, the disparities in health status grow. Also looking at populations of people over 65 with dementia who are not in nursing homes. So not so much at 65 and over. not so much, but when you start looking at 85 and over, 30% of people with dementia, 24% of 30% of women, 24% of men. So you really are, looking at cognitive impairment. Also, just in terms of healthcare costs for beneficiaries, you see how much higher they are for those people who are 85 and over. And I think this was a really valuable because it looks at out-of-pocket expenses. And on the left, at the different age groups, and you can look at just 2013, which is the darker line. On the left is the people who are poor or near poor in income category. And on the right is the people who are in low, middle, and high income category. So the impact is so much greater for people in low income in terms of what their out-of-pocket expenses are, even though that's the group of people who proportionately should have less out-of-pocket expenses. So we have kind of a disconnect in terms of more security, once again, for those people who have more funds. We also see, just in terms of the use of long-term care services, you see that really big bar, which is about home health services, like a growing industry in the country. And home health services are interesting because, social workers are involved in home health services, but they have to be ordered. The services have to be ordered by the nurse. It's not, so social workers are part of the team, but don't always get to be as they do in hospice, where they are required. And so a lot of times maybe the social worker doesn't get called in when they should. And then just some data about the distribution of informal caregivers. The left-hand bar is the percentage of caregivers, and the right-hand bar is of caregiving hours. So the first one is spouses, so 21% of spouses, but 31% of hours. Daughters is kind of equal. You see sons, a little smaller. I'm glad I had 2 daughters. Other relatives, and then non-relative caregivers. So caregiver is a really big issue. And then, a big focus of the Affordable Care Act has been particularly around dual eligible beneficiaries. So people who are both Medicare and Medicaid eligible, so that's older adults, it's people with intellectual and developmental disabilities, other physical disabilities, people with serious mental illness. And those are the high users of care. They're not such a large group of people, but they have worse health and higher costs. So what were the goals of the Patient Protection and Affordable Care Act, and how did they fit with these changing demographics? So the focus was around better care, affordable care, and we heard the news today about, well, it's not exactly as affordable as we thought it was going to be, but that's partly because enough healthy people aren't enrolling, because part of the way it was structured was to have lots of healthy people enroll in healthcare so that you could more afford the high users. And also a real focus on sort of prevention and population health so that you would have healthier people and communities. And it was interesting because I actually just had a physical 2 days ago, and a number of the questions that they asked were much more health promotion, and I belong to a Kaiser and HMO, and they don't charge you to get your physical. It's part of the standard care, so it's interesting. So the Patient Protection and Affordable Care Act, so how is it in terms of implementation? A lot of talk about better integrated care, so that's integrating primary care with behavioral health care, substance abuse, mental health services, expanded coverage to the uninsured, and it's advantageous if states chose to use Medicaid, and a focus on prevention and wellness. And then a big issue, which is paying for outcomes and not units of service. And I know when I worked at Northern Virginia Family Service, it was about units of service. You saw people for 6 sessions, or you saw them for 12 sessions. Didn't really focus on the outcomes. And I think that's one of the places that, as social workers, we struggle some with what our outcomes are and how do we demonstrate them. And I'll talk a little more about that. A second piece of importance in the Affordable Care Act is really focusing on quality. And there's a whole national quality strategy. And that's really about making care safer, ensuring that the person and family is engaged as a partner in their own care. So there's a lot of discussion about shared decision making. And I was at a meeting a few weeks ago with some interdisciplinary group of people, and I was sitting next to a physician. And she said, shared decision making, it's really a good idea, except when the doctor really knows best what needs to happen. I was like, well, that's the problem. Promoting effective communication and coordination of care, critical issues in terms of social work involvement. Promoting the most effective prevention and treatment practices for the leading causes of mortality, and working with communities, much more of a population-based lens to really promote best practices, and making quality care more affordable to more individuals, families, and employers. So those are kind of the national quality strategy. And so the government is looking at sort of a whole set of what they call levers or levers. In terms of, the importance of measurement and feedback, health information technology, public reporting, learning and technical assistance, workforce development, certification, accreditation, and regulation, consumer incentives and benefit designs, payment, and innovation and diffusion. So key areas of attention are addressing the social determinants of health. It's just fascinating how medicine and other groups have developed, have identified that the social issues impact health outcomes. I think social workers have known that for a very, very, very long time. The promotion and use of functioning interprofessional teams. Well, I'm sure that when I was trained in 1972 at the DTU, it was about interprofessional training, or interdisciplinary at the time, and it was about different leaders, different teams for different of the clients would have different leaders based on the sort of largest presenting problem. And once again, that kind of training that I had 1972 about the way that different professionals work together has carried me through my whole career and other projects that I did, particularly when I was at CSWE, on interprofessional education and training. And as a few years ago, we did a meeting at the Social Work Policy Institute on investing in the social work workforce. And one of the speakers was someone who had worked at CMS for a really long time at the Center for Medicare and Medicaid Services as the research director. And he was kind of going over some of the pieces of the Affordable Care Act that are quote unquote new. And he kind of got to this piece around interprofessional, and he's like, this is not new, but since it keeps coming up, it must be very hard to do. And I think sometimes we talk about interprofessional, but oftentimes when you're talking with doctors and nurses, I think they're talking about intermedical, because it's like a lot of times the team is the doctor and the nurse and the pharmacist, and doesn't include social work. It doesn't include engaging with the social supports. And also, one of the things from the project I did at CSWE in the 90s, when we were looking at interprofessional education and practice, one of the key issues we looked at was that there wasn't one profession that should be sort of always be part of the team leader. And I was at a meeting, and someone was talking about one of the new John A. Hartford Foundation initiatives, and it was about nurse leadership in interdisciplinary teams, that they were going to have a project through the National Center on Interprofessional Education and Practice at the University of Minnesota. And it was like, when someone's telling you that and they're funding a program you're working in, you don't want to kind of say, but, oh, we were taught that's, it could be nurse leadership, it could be social work leadership, it's not just one profession or discipline. Another key area of attention is this issue of shared decision-making, as I said. Another is focus on transitions of care and care coordination. And once again, those strategies have to be person-centered. There's a whole lot of effort, and health information technology is part of it in terms of communication of information. But if we're really looking at care transitions and sort of the large role that caregivers provide. We really need to be talking about sort of the interpersonal pieces of care transitions. There's the focus, as I said, on high users of care and the integration of behavioral health and integrated care. So what we know is that 60% of what determines health is social, environmental, and behavioral. But that's certainly not the way our health system works, but maybe that's a goal that we're trying to meet. And it certainly provides lots of opportunities for social workers. So where are the opportunities? Number one is terms of coordination, access, and transitions of care. I have, I'll talk a little more about it, but I have been serving since 2012 on a committee of the National Quality Forum. They have something called the Measurement Application Partnership, and part of that partnership is a set of work groups, and one is on dual eligible beneficiaries. And what they were doing was really looking at transitions of care, and they invited people who were doing different model programs. And folks from Oregon Health System came and they talked about how they had a grant from the Center for Medicare and Medicaid Innovation to do a care coordination project with dual eligible beneficiaries. And they thought they could do the project with community health workers, but it turned out that they were actually doing the project with MSWs because they found that the community health workers didn't have the level of sophisticated experience that they needed to actually meet the needs. As we said, like the most costly patients need those services. Social workers have opportunities to enroll the uninsured. There's, November 1st starts open enrollment again, and it's a great opportunity for social workers. And there's a number of social work organizations and some schools of social work that have been actively involved in enrollment. Certainly, social workers are key members of the team. I think that also one of the social work strengths is really kind of a focus on sort of working on health literacy and understanding community and cultural diversity and sort of the issues of equity or inequity in the health system and inequality in the health system and delivery. And then also, although some people might debate this, I think social work does have a long history focused on prevention, health promotion, and wellness. And some people of more of sort of a public health ilk don't always see that. But I think that really has been an important area. There are social workers who are working in churches around breast cancer screening, in communities doing all sorts of health projects. And I think it provides great opportunities for the social work profession. And one of the challenges, I think, is also an opportunity, and that's really around integrated care. Because as we talk about behavioral health being integrated with primary care, it's a dilemma in some ways because social workers, to some, including in some federal programs, are only categorized as behavioral health providers. But social work has a long history as part of the healthcare team and in healthcare settings. And so in integrating primary care with behavioral health care, you really kind of need social workers who are providing both of those. It's not like you can expect the person who's providing the behavioral health services to also be doing more of the healthcare coordination. You sort of need both of that. And I think those definitional issues sometimes are a challenge in terms of the policy arena. So I wanted to talk a little about some of the innovations, kind of social work innovations I've seen in this. Luckily, the room is nice and big, and this stuff is much more readable than I thought it might be. So there's really been sort of two key places where there have been a lot of funding for innovations in healthcare delivery, and one is through the Patient-Centered Outcome Research Institute that was created as part of the Affordable Care Act, which is kind of a private entity that gets federal money, and the other is through the Center for Medicare and Medicaid Services, Center for Medicare and Medicaid Innovation, and a number of different projects have been funded through that and other earlier Medicare reform efforts. One model that regularly uses social workers that comes out of Indiana University Health System is the GRACE model of geriatric assessment that uses a social work and nurse team, and is being now implemented around the country. Another model that has strong involvement of social workers are some of the models that are health homes. So there have been the integration of primary care actually into behavioral health programs. And a lot of those have been demonstrated also through the Substance Abuse and Mental Health Services Administration. And then one of the projects that I've been involved with is something called Project Achieve. It's funded by the Patient-Centered Outcome Research Institute. And it's a project that is, I think it might be PCORI's largest grant that it funded. It's like about $15 or $16 million. It's a multi-year grant. It involves the University of Kentucky, the University of Illinois Health System, Kaiser, Boston Medical Center, the nursing school at Penn, and a few other, Westat, to do survey. And what it's really trying to tease out is in transitions of care from a patient and caregiver perspective, what are the critical elements that are needed to have successful transitions of care? And while many efforts over the course of my career have really sort of looked at, wanting to engage stakeholders who are actually people with lived experience, this is the first project I think I've really been on that really totally honors that and really has given a great deal of focus on sort of the voice of patients and the voice of caregivers across about 6 different diseases. Lung disease, heart disease, many sickle cell anemia, many different areas. And so it's kind of an exciting project. They did a lot of information gathering, and now they're out trying to engage hospitals and health systems and trying to test out some of what they found. So it's something to stay tuned for. And from my perspective, social workers have very key roles to play in transitions of care, but I don't think it always plays out that way in terms of health systems and health delivery. It could be someone wearing many different hats, and I think also in some health systems and certainly in some hospital systems, the social work department or the social work roles have been kind of muddied and may not always have as good relations with others as one would hope. That's my total personal conjecture. And then, as I said, there's been major focus on the dually eligible beneficiaries, and I'll talk a little more about that. And another piece is really this sort of engaging, sort of linking together health systems with community-based service providers. So as one builds accountable care organizations and one looks at transitions of care, like the John A. Hartford Foundation is really involved with efforts working with area agencies on aging to work to kind of connect them with health systems so that the area agencies can take on a stronger role on a more for like fee-for-service basis around community-based service delivery and sort of change their sort of role, and particularly Hartford's been working with them on sort of business acumen, because most of their work over the years has been sort of grant funded, and this really kind of changes it if they become tied up with the health system. And I think there are some key transitions of care models that use social workers. Robin Golden at Rush University Medical Center, the AIM program, Bridge, as I mentioned, in Oregon, also Washington State, in their work with dual eligible beneficiaries, also uses social workers. So what are the challenges that the social work profession faces? One of them, as I said in the beginning, is really about measuring psychosocial interventions. We have not put enough focus on that. The Institute of Medicine convened a group about 2 years ago, NASW was one of the sponsors of it, along with the American Psychiatric Association, the American Psychological Association, the VA, the Substance Abuse and Mental Health Services Administration, NIMH, funded a study really looking at quality psychosocial interventions and how they're measured. And that was partly because some physicians and the former head of the National Institute of Mental Health, Steve Hyman, kind of was saying, with drugs, you sort of have a sense of, this is the amount of drugs you give and this is what you get. But when it comes to psychotherapy interventions and many of the other supportive employment, many of the other interventions that are more psychosocial, we don't have such good measures of them. And so there's a work group now in social work that's taken the recommendations from that Institute of Medicine report. And I know they'll be presenting next week at the Council on Social Work Education on some of the work they're doing. Another challenge, once again, is a role on interdisciplinary teams. Are we on the team or not? New nursing home regulations just came out. In the draft regulations that had social workers as part of the interdisciplinary team. From what I understand, somehow when the new final rules came out, that social workers are not part of the interdisciplinary team. And part of that is because there aren't all those social workers in nursing homes. So it was like this catch-22, because in the draft rules, there were so many roles for social workers, and we kind of said, this is great, but then you have to change the requirement for how much social work you have, and the education of those social workers. And so they kind of went down instead of rising up. I think another challenge that we face as a profession is the work that we do that others can do. Do we do it better? Sometimes we do, sometimes we don't. So we have competition with other professions, whether it's nurses, mental health counselors, marriage and family therapists. And we also have competition with community health workers, navigators, peer support. So we have all these new groups and a lot of focus, and a lot of the focus around workforce development is related to like training of community health workers and things like that. And out of the Affordable Care Act, there was a number of training opportunities that were for social workers and psychologists were at first the only ones who could apply for them. And social work took really good advantage of that. And then there were sort of going to be more workforce development efforts. And probably because we weren't playing effectively with our colleagues in other disciplines, when the next announcement came out, it was kind of like, well, we won't let social workers apply because they were so successful in applying for these other ones. And, probably that happened because my conjecture is that some other discipline that felt like they didn't get their fair share because social work was doing really well with the funding probably went to a member of Congress. The member of Congress probably wrote a letter to the Health Resources and Services Administration, HHS, and said, we need more opportunities, so, we need, all those social workers already got funded, so we don't want to do that. That's just my conjecture. I have no proof of that whatsoever. So what are we doing? Are we preparing enough social workers? And what are some opportunities? So one of the things that I've been involved with over the last 2 years, the New York Community Trust, which has nationalized its funding, it has funded a project called Social Work Heals. It's a collaboration between the Council on Social Work Education and the National Association of Social Workers. 10 schools were selected to provide BSW and MSW scholarships to students to kind of help generate the next generation of healthcare leaders. There's also, for their field instructors, there's actually going on right now at the Society for Social Work Leadership in Healthcare, there's like advanced, some training for the field instructors. There's also, we're 5 doctoral fellows, and one of the fellows is actually from the University of Wisconsin, Madison. So there was enhanced funding for 5 doctoral fellows who are studying significant healthcare issues. And there's also a policy fellow, Janine Cross, who's spending a year in Washington working on health policy issues. It's a 5-year project. The students each year come to DC for a policy forum. to really, as I mentioned before, hear from social workers who are doing policy, to go up on Capitol Hill and meet with members of Congress and their staff. So it's a really exciting project. Another project that the Hartford Foundation has funded is something called Supervisory Leaders in Aging. It's a project that is focused on MSWs who are working in community agencies providing social services to older adults and who are supervising other staff. And it's providing supervision training, leadership development, and expanding gerontological expertise. Because we know that a lot of social workers now don't get training in supervision, and yet they become supervisors pretty early in their career, and that's being piloted in 4 NASW chapters right now with the hope that it could go national at a later point. And as I mentioned, like with nursing homes, we have a need to address weak policy and regulations. One of the ways that that's happening is NASW has the Improving Access to Mental Health Care Act of 2015 that was introduced by Senator Debbie Stabenow, who's a social worker, and Congresswoman Barbara Lee, who's a social worker. And it addresses Medicare beneficiaries in 3 different ways. One, it would increase the rate for which clinical social workers are reimbursed to 85% of the physician fee schedule, which is what other healthcare providers are reimbursed for. Social work now gets reimbursed at 75%. Psychologists get reimbursed at 100%. The second issue would allow for social workers to get reimbursed by Medicare if they provide clinical social work services to someone in a skilled nursing facility. In most states right now, Medicare won't pay because social work, but not clinical social work, is part of the nursing home bundle. And it would also ensure that beneficiaries had access directly to clinical social work services using the Health and Behavior Assessment and Intervention Code. So those are sort of some of the ways. I talked a little about efforts to sort of influence clinical social workers. I could talk a lot more, but I've skipped over some of my slides, and I'll just let you ask some questions. So thank you very much. So the question was, has there been much attention in the aging world to elder abuse and neglect, and particularly in health settings, and what's kind of going on there? So there's actually a lot going on there. I'm not sure sort of under what aegis. I don't know if it's under the Administration for Community Living, but there's been sort of a commission or sort of work group, kind of a high-level group, because this was one of the key areas that Kathy Greenlee, who was head of the Administration for Community Living, was one of her priorities to really sort of better address elder justice. There's also been some work at ACL around competencies for adult protective service workers. The John A. Hartford Foundation, their new head, Terry Fulmer, who's a nurse, a lot of her work has been in the area of elder mistreatment, and so they have some special initiatives that they're going to be doing, particularly about elder mistreatment and in healthcare, and sort of better informing healthcare providers of signs to look for, so that if someone, we were talking about it recently, like if an emergency medical person goes into a home to get an older person, like observing what they see in that home, that would give them triggers of what's happening. And I think that also speaks to the sort of broader issue of better integration of health services with social services, because just like we see it for kids, it's true for older people also, that there are such needs, and a lot of times also, particularly, people will have symptoms of something that are it's because of poor nutrition or things, and you can sort of learn things about it, but I think the elder justice system is under a lot of constraints also, because it's not very robust, and a lot of adult protective service programs are funded through the Social Services Block Grant, which never grows. Yes. So, do I have any clever solutions? No. So the question was, one of the things that you see, particularly in hospitals, is that you have a growing focus on nurse case managers, and they're getting reimbursed by Medicare. Are there any easy solutions? So, it's really difficult because I think that there has been a sense of ownership in the social work profession about case management. I talked about Carol Austin before, who was a Ph.D. graduate of the school, who was kind of one of the national leaders at a time, around issues related to case management and issues of care coordination, and we haven't kind of kept that ownership. And we get involved in these sort of definitional issues because social workers, clinical social workers, the definition is very narrow in Medicare for clinical social workers, which is about the diagnosis and treatment of mental illness, and is not a broader array. So that's one of the things that we're really trying to, NASW is trying to do with the Improving Access to Mental Health Care Act, is to broaden the definition, so that would help also with reimbursement. And I think also there have been efforts organizationally to help, like right now, the National Association of Social Workers through the Professional Development Office has been working with one of the case management certification bodies that mostly is certifying nurses to sort of open up the opportunities for that certification for social workers. So that, is not an answer, but there's a lot of issues related to definitions, and sometimes they're not as much of barriers. I was working with people in a Medicare managed care program a few years ago that Aetna was doing, and they had hired 1,200 social workers who were basically working at Aetna. These are people who are not hands-on. These are people who are in the office providing care coordination efforts, but they were all in positions that were called nurse positions. But they were social workers, and Aetna felt very strongly that it was the social work skills that were really important in terms of the work, but they didn't have social work positions. They might have changed by now, but it's definitely an issue. Mel? So the question is, are the jobs and opportunities for social workers and aging really growing? Because that's what the Bureau of Labor Statistics said was going to happen. And secondly, are we attracting enough social workers to work in aging? And I reflect back, so when I was here in Madison, it was 1974 when I was leaving, and people were all coming, Martin Loeb had all this aging money, and people were coming to Madison because it was kind of a bastion of aging expertise. And then it all kind of died away for a while, and so really the infusion that's happened in social work really has come about mostly from the John A. Hartford Foundation and the efforts that they invested in terms of student development and faculty development. Yes, I think the opportunities are there. I think, just looking at some of these assessment models, managed care models, coordinated care, transitions of care, they all provide opportunities for social work as well as integrated care. So it provides a whole different dimension of social workers who are providing clinical services, and social workers are the largest providers of behavioral health services. So I think the opportunities are definitely there. I think it continues to be a challenge in terms of attracting students. And part of it also is I think there's a lot of people who move into aging. But also statistics, when you look at what people do, they say, well, I'm not working in aging, but I'm working in health, and 70% of my clients are aging. Or you're working in child welfare, and you're working with grandparents who are taking care of the kids. So I think, there've been a lot of effort to sort of reframe people to attract them into sort of aging as social work as a savvy profession. But I also think we need to do a good job of helping people sort of think about their career transitions also, because I know a lot of people who maybe started out, oh, I'm going to work with kids, or I'm going to do this or that, and they end up working in aging and find it very satisfying. So, those are some of the pieces, and I hope that the investment that Hartford made over, 16 years will have some lasting benefit, just as the 1970 efforts that the Administration on Aging invested would have some lasting efforts. And I think things like, trying to sort of improve the adult protective service workforce and other kinds of things like that can also provide opportunities for aging, as well as I think some of the behavioral health money that through I don't know if Wisconsin has any of those grants, but some of them have been aging focused as well. And the VA, that's another place where they're, it used to be we said that they were the largest provider the largest employer of social workers, and they had 3,000 social workers. Now they have like 12,000 social workers. So I see you're standing here.
And also, before I thank Joan, we did a survey of our alums, and it turns out that although many of our alums did not specialize or did not picture themselves going into aging, it turns out that most of our alums end up doing aging as a part of their job. So I think we are seeing that in surveys of our own graduates as well. So I want to thank Joan so much for coming and not only speaking with us here today, but she spoke with a lot of our students today and is going to tomorrow. We're working her very hard while she's here. And thank you all for coming out on a late afternoon. Thank you, Joan.